Thank you. Can you guys hear me okay? All right, good. Ironically, I'm at a healthcare conference speak, and I've got a cold. So hopefully my voice will kind of project through. Yeah, I know it. Safe distance, safe distance. But hello, everybody. I'm DJ Penix. I'm the president and founder of Pinnacle Solutions. We've been a SAS partner for over 30 years. So I've been helping solutions around the SAS ecosystem for a long, long time. I'm also the Chief Product Officer for Predictive Health Solutions. And I'm proud to present here Vicki, my co-speaker here. Vicki, if you can introduce yourself.
Sure. So I'm Vicki Gregorio. I'm the director for the Center for Discovery, Innovation, and Development at Children's Specialized Hospital. That's a mouthful, so please don't make me repeat it. Children's Specialized Hospital is a preeminent rehabilitation hospital within the state of New Jersey. We have 15 locations across the state, many which are outpatient sites, but inpatient long-term care. We serve nearly 50,000 kids with unique healthcare challenges every year. So there's definitely a lot of work that we want to do with healthcare and making sure that we serve our patients really well. So with that, we'll get started.
Yes.
So DJ talked a little bit about Predictive Health Solutions. So Predictive Health Solutions is a joint venture between Children's Specialized Hospital and Pinnacle Solutions with SAS as a partner. And our goal is really to effectuate change in a healthcare setting and utilizing our expertise as operational experts in healthcare and DJ's expertise as a data science, right? And realizing, we need to bring those minds to the table and a wonderful partner in SAS too for how we can, make those solutions come to life. So I know there's some lights on me, but I'm going to ask a question real quick. I promise I'm not going to call on anybody, but real quick, show of hands, how many of you are from a healthcare organization? Amount of you. How many of you are data analysts, data scientists, like data geeks? All right, so like a split audience. Okay.
Yeah.
How many of you have been a patient that's gone to a doctor's appointment?
There, we got him. We got him now.
Awesome! Awesome.
Right.
So this is going to be relevant to you no matter what. Okay, great. So the topic we're going to talk about today is really, we thought it would be helpful to give, make it a tangible example and talk about a case study. So we're going to talk a bit about our work with the no-show solution. So the no-show problem. Again, show of hands. I want to just get nods. Does everyone know what a no-show is in outpatient? Yes, no. Yeah. Okay. For those who don't know, I'll give a quick explanation. So a no-show is when someone schedules an appointment and then they don't show up to said appointment. Late cancel is that, just that you have an appointment and you cancel maybe a couple minutes before and we're unable to fill that spot. It is a major issue that is affecting healthcare. It's creating bottlenecks, increasing wait lists, especially as we're having limited supply of providers, especially in specialty care. So that's something that we find as a major challenge. And with PHS, we figured let's use our expertise, right, to come up with a solution that can help with this problem. So I'm not going to go through all of these key numbers. You can read through some of them. But it is as I mentioned before, it's a known problem. 15 to 30% of all outpatient facilities have a no-show rate. That's the average no-show rate. And it's estimated to be $150 billion national in the U.S. healthcare challenge. And it is exacerbated by long wait times. I can tell you at Children's Specialized Hospital, our no-show rate is in that average. And we have some of our wait lists for kids, 6 months, right? 6 months to see a doctor for a particular neurodevelopmental pediatricians. In the nation, there's estimated 500 neurodevelopmental pediatricians. And we have a lot of them. So imagine someone missing that appointment. And that affects so many people, right? It affects the kid that should have seen that appointment that really needed that care. It affected another kid that could have utilize that appointment time. It affects the provider, because providers are also motivated by productivity hours, right? They have to see a certain amount of patients, they have to, bill a certain amount, so that affects their productivity as well. And then also, listen, we're a hospital, we're a pediatric hospital, but we also have to keep the roof on, pay the bills. It also affects the bottom line of the organization. So it is a major pain point, and it doesn't just affect us. That said, we have a nice video that we'd like to show you guys about some of the work that we have done at Children's Specialized Hospital. So, guys in the back, please take it away.
When patients show up for their appointments, they do more than receive the care they need. They also deliver the revenue providers count on to meet their financial goals. Here at RWJ Barnabas Health Children's Specialized Hospital, optimizing schedules didn't happen by chance. The patient no-show predictor from Predictive Health Solutions has helped make it possible.
Like all kinds of healthcare organizations, we had a challenge with patient no-shows. When patients fail to show up for their visit, their care is disrupted and discontinued, which can lead to poor health outcomes and more trips to the emergency room. Plus, operational efficiencies in our offices decline. Our schedulers have to scramble to fill appointments. Doctors and nurse practitioners may have to see patients that they weren't planning to see. This increases the stress in the workplace and can lead to poor employee engagement.
There's also a significant financial impact of no-show and cancellations on the organization. They can range from anywhere from 18% to 22% of total appointments for organization, which has a significant impact on revenue. When someone no-shows or cancels, they're denying an opportunity for another family to have taken that spot. And more importantly, that particular child on that day did not receive the treatment that they needed to help them reach their full potential.
We've had families on the wait list to see certain providers. When a patient misses an appointment, that slot goes unused, and that can be a very frustrating experience for our parents. All they want to do is have their child seen and treated.
We needed to find a solution. We tried everything, from reminders to overbooking.
Today, healthcare is increasingly turning to cloud offerings to enhance interactions with patients and improve care.
So we partnered with the Center for Discovery, Innovation and Development and Predictive Health Solutions on trying to find a way to effectively reduce no-show cancellations.
So together, we developed a cloud-based patient no-show predictor. This practical tool, powered by SAS and Intel, gives healthcare providers the power to anticipate, manage, and minimize patient no-shows. It's a fully integrated solution that uses existing data and advanced analytics capabilities to calculate the likelihood of a missed appointment or a late cancellation, and then determine optimal strategies at the individual and aggregate patient level for reducing no-shows.
Intel is powering predictive analytics from SAS for the latest state-of-the-art solutions in healthcare.
The patient no-show predictor has been very easy for our staff to use. The tool features interactive dashboards that enable staff to identify the most likely no-shows and then customize intervention strategies, whether that's a weekly text, a single call, or a virtual appointment where appropriate.
We have seen some very encouraging results. In just about 3 months, in some of our clinics, we've seen about an 8.5% reduction in no-show cancellations. In one particular clinic, we've seen a 63% decrease in no-shows. Through this creative solution, it has enabled us to really take a deep dive into what's driving our no-show cancellations and map it to real solutions to effectuate meaningful reductions and also a significant increase in revenue associated with those reductions.
The implementation of the tool has helped so many families get into necessary appointments. This has removed so much anxiety from their lives and the lives of their children.
The tool continues to evolve. The models measure the impact of interventions and are refined to ensure optimal performance and insight. It's one more resource that can help patients have access to the best possible care and help providers optimize their schedules.
To learn how the patient no-show predictor can work for your healthcare organization, get in touch with Predictive Health Solutions to schedule a conversation.
Well, Vicki, I think our work is almost already done, right? I mean, it presented most of it for us, but pretty amazing stuff here that we've been doing, so.
Absolutely, absolutely. And what we noticed too, if you were at the session this morning, right, we talked about, where the future for AI is heading, where we've done a lot that's already been accomplished, but an area that we haven't really tapped is access to care. So that's something that, through the work that we're doing with PHS and our solution here, this is something that, would enhance that access to care with no-show, right? As one example. So with this, what makes our work different is that, DJ will go through more of the technology pieces, but technology was, quote unquote, the easy part.
That's my quote, by the way. That's not Vicki's quote.
I know, I'm sorry, I'm stealing
technology
it.
really is the easiest. You had the hard stuff, right? So that was my bullet point that I threw in there for her.
Yep. So, and really it became a combination of people, process, and tools, right? So realizing that we needed the right people at the table and we needed immediate buy-in, not just at the beginning, but through the entire process. So what DJ will primarily be presenting is some of the work that his team put together with our input, right?
Yes.
To really, help us understand our no-show problem, and then also give us, ideas to test drive some of the actions that we could do, and then see whether or not our actions pretty quickly were effective.
Yes.
Right?
All right, so here's the technical stuff that I get involved with, right? So I tried to keep this high level here, but the interesting piece on all this is I'm very passionate. Those of you who know me, I've dealt with a lot of medical issues in my life. I have been a very stable, consistent patient in all realms of areas. And so there's nothing more frustrating and in combination with stress when you're going to see a doctor when you actually not only show up on time for your appointment, but you're there, you're early, and everything is still disrupted, right? I never really understood what happened behind the scenes with your operations, right? And so I thought of it from the perspective of how do we just provide a patient score, right? It's almost like a credit score. What is their probability of making their specific appointment or not? Right? And so when you hear, I know there's been several presentations this week, starting today, and you'll probably hear them before. Try to find one simple task. How do you utilize AI? Find one little simple task. And we thought this was it, right? It's just getting a score, taking all of the patient appointments and then getting the score. So what we did, even though it was still a simple task solution in our minds, we still felt that we wanted to have a full model lifecycle development platform that was available. We could have done this in Python, we could have done this in R, we could have done this in other solutions, but because we wanted to make this real live stream, dynamic, iterative cycle among itself, SAS is really one of the only commercially available platforms out there that will allow us to do this and to make it scale and to be able to add other solutions down the road when we add on top of it. So when we think about what is the traditional appointment database, the appointment database, that could be your EMR system, your Epic is the most common, whatever it is. And we all know that SAS will connect to anything that's out there, right? So the crux of every model is getting historical data so that we can build the models on it. The other key point, and where we were a little bit of a differentiator and where the SAS toolset came in, is this concept of an enrichment database. And that's taking other data points and other factors that go beyond what's just in the electronic medical record platform that we can feed that into the model. We're going to take a little bit of a deeper dive into the enrichment database here in a second. So a few of the different things that we can do with the enrichment, a lot of this stuff is free. It's stuff that we can download. It's stuff that we can, get on the internet or pay for a simple API service. Things like demographics we can download from the Census Bureau. There's a lot of weather APIs to give us real-time weather data, things like that. Lifestyle, social determinants of health is a big one. I know that healthcare right now is a big hot topic. We can feed those things in there. Method of transportation. Is the parent like a single mom who has multiple kids and she's juggling between appointments and getting the kids to school and so forth? None of that stuff is in the EMR system itself, but they're all areas that SAS can not only pull in, but can help orchestrate and to help bring it all together. So these are some of the things that we've kind of thought about that. And then if you could go back one more slide, Vicki, if you can go backwards. So those are the two data sources there, but it's really more than two because that enrichment could come from all over the place. And SAS can help orchestrate all of that, bring it all in together, funnel it, get it all in real time. From there, that's where we use SAS Viya. And by the way, we have this hosted up in the cloud on AWS. We use really no PII data at all. We don't want any PII data. The one thing that was a little bit questionable of what we could use is street-to-street address. So we could use the street address when we get into directions or mapping or weather or things like that. But really, zip code is enough. We don't want to know the patient name, their numbers, anything else in here. Then we use SAS to build the models. And then we come up with what we call a score, right? Think of it much like a credit score. It's the probability of a number between 0 and 1 that is your probability, excuse me, of actually making your appointment or not, right? Then we come in there, then your team can take those results and then they can take the corrective actions with it, right? So they can make a decision. Do we need additional follow-up? Do we need to enhance our email, our text, our phone reminder system, so on? But then the cool thing about this platform is that after the patient either showed up or didn't show up, we feed the data real time back into the database. So we can actually update our models on a daily basis in real time. What is our champion today may not be our champion tomorrow. We literally, as the nuances of your business, your patients, COVID hits, anything else, our models, our characteristics will change, but we're on top of it. We have real-time access to it. You can't get that with open source or for non-productionalized model development systems, right? So that was the good piece of that whole flow, right? Now I'm gonna take a break while you...
Absolutely. So, and it really, like the other thing that we were monitoring through this was solutions, right? So as we were looking at some of the things that we thought were pain points or problems, right? Because of how quickly your team was able to, update the models, we were able to quickly shift gears. If there was something that we found, hey, this isn't necessarily working for us, or let's try it, and maybe it's working really well for us, and we need to put more resources behind it. It was really quick to show us whether or not things were effective.
Absolutely.
So we weren't wasting our resources, and we were helping our patients get to their appointments.
So here's a couple of other examples of, again, how you could use it. Because as we've been talking with other organizations, they're like, hey, DG, we're using phone reminder systems. We're using text messages. We're doing multiple reach outs, email reminders. And I'm like, how's that working? Well, our no-show rate is still our no-show rate, right? But the other good thing is we can actually feed all of that data input into the model, right? How many of you guys have ever complained, like, golly, my doctor keeps texting me about a reminder. I have never been late or a no-show ever, and they keep sending it to me. Use that insight to give them a more personalized, customized experience, right? Or the fact that if we do have door-to-door directions on it, we can actually hook up to a Google API map. How about when you send them that text message, you give them a more personalized and customized message that says, oh, by the way, beware, you've got traffic. You got construction on this one. Instead of the normal route that you probably take, you might want to take an alternate route. Or the fact that we can actually create APIs on the solution to get real-time scores. So at the time of booking, when somebody calls in and they say we want an appointment, we can actually see in the head that they're saying 8 o'clock in the morning. Well, 8 o'clock in the morning may be a little bit busy with rush hour. Maybe we ought to, give you a better chance of making your appointment or not having to cancel it at a different time, right? So leverage and utilize what you have, whether it's the email or the phone reminders, but use the technology to actually make it a more personalized experience on a patient-by-patient level.
Yep. And in addition to that, right, so that's like what I call a micro, plan, right? So some of the other things that we learned through this was that the tools that could tell us things about the micro level. And when I say micro level, like the unit of analysis being the patient by patient, but also some macro level changes that we were able to, look at as well. So an example, if anyone's familiar with Jersey, the Fridays by the shore are traffic central. We have a couple of sites that are by the shore. And so some things that we have started to look at is, do we schedule new patient appointments on those Fridays during the summer hours? Is that the best use of our time? Do we move it to another day? Do we have people come in a little earlier, intentionally tell them to come in a little earlier during those high traffic periods, right? Because for our appointments, and I know overbooking is something that a lot of practices use when you have 15, 20-minute appointments, but a neurodevelopmental evaluation appointment is 90 minutes. We're not gonna overbook a 90-minute appointment. Or a PT appointment for, in pediatrics, we have to do those one-on-one for 60 minutes. Again, we're not going to, overbook that appointment. But what we could do is do some things with planning and utilizing this to how we effectuate things on our end, because we can control, it's easier almost to control what we do as an organization rather than controlling patient behavior. Although we do our best to establish relationships, like you said, personalization, that's certainly things that we had done as well. But the two together really, really helped.
It was an amazing thing from my standpoint. I've always felt like this no-show problem was always a result of the patient behavior.
Yeah.
Right? Well, not my behavior. I'm doing good, but patient behavior. And that particular instance brings to light that organizations many times, they make these assumptions, but it wasn't their fault. It wasn't our fault. It wasn't your fault.
Yeah.
It was just the nuance of the environment that was there. But it gave you some insight into it to optimize your workflow. And without having a real-time system in there, it wouldn't have come to light.
Sure.
Yeah. We got one more example here. Same thing with traffic, but the same thing with weather that comes up, that you could do the same thing. Hey, by the way, we've got a weather storm that's coming up. The other thing that I wouldn't say you guys threw us a curveball, but I thought it was kind of a binary type of problem we were gonna fix. But then we brought up this concept of not only a no-show, but it was a late cancellation and an early cancellation, right? So maybe they called in 3 days in advance, they canceled it. Then there's the dreaded, it's an hour before, or they don't show up, right? Or they last minute, hey, I can't make it, right? All of those have different impacts on it. But knowing ahead of time, right? And you'd prefer that they cancel it early rather than last minute, right? And so that was another nuance that we actually implemented. So we define no-show as being also late cancellation, early cancellation, no-show.
Yeah, absolutely.
This was the original concept. And again, I can't emphasize enough about this, process of, as you guys are diving into AI, no matter what it is, whether you're healthcare, whether you're any other industry or problem, try to find a simple task solution that you can apply this to. When the topic came up, it was, we want a spreadsheet. Here's the list of all of our patients that are coming in, and we want a probability score of whether they're gonna make it or not, right? This was actually done on a desktop PC for SAS, right? It would just export that. We'd email the spreadsheet to the operations folks. They would then score it and rank it by those that were read, and then they would focus on them for calls and follow-ups, right? That was the start, and it was really a really great start for that. And then it kind of snowballed from there. And then that's when we started getting into more sophisticated dashboards, building the workflows, and so forth. But you can see conceptually, get started somewhere.
Yep, and it was interesting too. So one of the things that was nice from the ground level was that we were giving these spreadsheets to our operations folks, and then they were sending it to our clinicians to kind of do something about it, right? But clinicians don't necessarily, I had a speech therapist call me one time. And we have a really nice relationship, and she calls me, she goes, Vicki, I went through years and years of school as a speech therapist, but no one taught me how to use Excel. So, so what we ended up doing was we made a little video for them to show them how to use Excel. So that's an example too, and it seems like a simple thing, but you have to think about your users' capabilities, how they understand data and meet where they're at. And that's not saying don't give providers Excel, but don't always just assume that when you're giving them something that they have the same knowledge that you have. ask them questions, ask them this is something that they could work with. And then when we were able to do that, we got, again, more buy-in. There wasn't like this scary thing about AI. And it made it much more tangible for them to work through. And then also it helped with resources. So, those folks you see the red, like, I think you guys can figure it out, the reds are the ones that are the problems, right? Like the problems in the oranges, and it gets better to green. But from there, it helped us with resources. Yeah. So if we were gonna go and have a clinician call their patients, without this, they might just call anybody. But here, they can utilize their limited time that they have to really, foster the relationships with those that really that need it the most.
Yeah, I think our PowerPoint is coughing like me, so we'll get that fixed. It needs a little sip of water.
I think this is the next one?
Yeah.
Yes, it is. Okay.
Yeah. So you've seen a couple of the screen captures on the video here. We'll show some more. We're happy to, talk to you guys more about it. But this, again, is built on the Viya platform up on AWS. And the other beautiful thing, and I think you may hear this in a common theme in these discussions, was involving the technical people with the people who have their hands on the application. Right? So while it started with a very simplistic, here's a sheet with all the ranking of the patients, it then turned into what would help you? And a lot of the people had some different ideas about, well, we think this particular clinic or these particular days of the week or these, and we just let them all have at it, right?
Yep.
And so we started building these reports and dashboards based on what they thought that they could help do their job, and then they would give us the feedback, and then that's what we designed it around. And then the Viya platform allowed us to do that.
Yep, and from our perspective too, we have different leaders for different clinics, right? So it also was able to highlight folks that were also doing really good things, so that folks would be like, well, what are your best practices for reducing no-show? Maybe that's something that we could utilize. It actually had people working more together than working in these silos. So that was something that was really helpful, a process that we learned along the way as well.
Yeah. I think we've got a couple more examples here. Certainly by clinic. And again, really the application is customizable to whatever data you would have in the organization, right? And so none of this is hard-coded based on clinic and so forth, but these were the initial variables and stuff that we all thought that we'd have some levels of interest. But the system today is we're ready to go. If we ever get anything brand new as a data source, it feeds in and we can automatically populate it in there, see how it produces with the models. Does it help with the prediction rate or does it hurt it, right?
Yep.
There's another one, and again, for those who have seen a lot of it, the drill down reporting capabilities allows them to go in at layers to be able to look through all the data, and that's the power of the Viya that you guys have.
And I know this is not real data, but this is something that's interesting, because for HIPAA,
That's
I'm just
true.
putting this all out there. This is not real data, but this is a real example I wanted to point out too. This is something from the operations side. So obviously patient, this is cancel reasons, folks, why they're canceling, because we're not coming this from no-show. But like patient illness, duh. Like that's gonna be the number one reason people are calling out last minute. But then number two is patient cancel, no reason given. That's a lot of appointments that we have no reason given, right? So, and that's not on the data side.
No.
That's on us, right? So that, that was something that we were able to learn and then go back to our operations team and our schedulers, who are typically the ones that are, working with the families as a late cancel, to be able to capture better data so that we can understand more reasons and then put that back into the model to help us, again, see if there's anything we can proactively do.
This was another interesting capability that, again, Viya has here for geographic, mapping and distance. So always interested in seeing, there's an assumption that the farthest, longest distance of the patients might have more of a higher probability of being a no-show. Not necessarily the case, but visually we can utilize the geo maps to understand where the clinics are location. And again, in a heavily densely populated area like Jersey, this is this is pretty important. But I would imagine even if you're in a rural area in South Dakota or somewhere else, it would be just as important for people who have to spend hours of driving time or even an airplane to come to the site.
Correct. And this is something too that this tells you about how the solution is unique to each unique facility. So for us, we're specialty care. So, if you need to see your child needs to see a pediatric neurodevelopmentalist and you need to get to that appointment, people are going to drive an hour or more to get to that appointment. Or a pediatric physiatrist, they're going to make that drive. They're going to make that distance. Would the same results you see here be for a typical urgent care? Probably not. So or a typical pediatric clinic? Probably not. So this is something that, again, it's important for the organization. These are case-by-case basis, so not generalizable.
This was a really nice feature too, the auto explanation. For those of you who have ever seen that in the Viya application, black box. People have talked about that. In healthcare in particular, I would say that that's the industry that has the most, suspicions and AI, we don't know what we want to do about this, help us explain it, right? And this is an awesome feature that allows us to see the correlation of the highest variables of what's affecting the no-show, right? There are other applications out there. I had another company I was talking to, another hospital. They use Epic. And they said, yeah, but DJ, we have an Epic. We have some analytic modeling that we can do, right? Well, part of the problem, again, as we discussed before, is bringing in outside data, stuff that goes beyond what's outside of Epic. SAS can handle that. But the other part is explaining the detail around why the rate is what it is. SAS can give that. And we can give that in an explanation either on a dashboard, or we can also, with the auditability of the models, we can provide that to the people. You can't do that with other black box modeling, right? So this is something that was always of interest and was one of, I think, from some of the first steps of at least gut suspicions of, yeah, we think it's this or not. Let's take a look at this first and see if it's correlated.
Absolutely, absolutely. And we're also on Epic, but and Epic is a really powerful platform, a really powerful, tool. But it's, it's not something, I hate to say, I feel like there's this intention, there's a competition, you have to just use Epic.
I wasn't going to put you on the spot with Epic.
But it's also, but it tells you that, you can utilize all kinds of different tools with Epic, right? So that you can go even beyond that. So it's wonderful.
Yep.
This is my favorite one, but I'll let you talk.
Yeah, so this one goes into the concept of, these experiments that you had done, and I'll let you go into that with a little more detail, but again, emphasizing the fact that we had a real-time dashboard that allowed us to implement change in our processes, in our workflow, and having the real-time dashboards that could track the change, right? So at any given point in time, we could get our baseline and then say, hey, we're going to change how we schedule appointments on Friday afternoon in the summertime. How is that impacting our no-show rate, right? So that was pretty critical there. If you want to go into that.
No, and again, this is actually, I know this is not based on our data because our highest no-show, and I'll just be transparent, is around September in New Jersey. Schools start after Labor Day. So the number one time that we see a huge peak, everything's nice and stable. And then September happened, it's all crazy. Probably, and I have kids myself too, so I'm all crazy as well. So again, but it tells us about seasonality and about resources and messaging. So we are able to prepare, utilizing that summer time to transition our families. So we know September is going to be a tough time for our families. That's when we have our clinicians or our schedulers or someone from operations, or we have family faculty. Family faculty, by the way, for us, are parents that we hire. They've raised a child who's come to Children's Specialized Hospital for services, and they act as an advocate for all the patients and other families too, and they give us a lot of great perspectives. But what ends up happening is, we utilize that time in the summer to really prepare for what we know in September. Now, September continuously is, it's never going to be a zero issue. But we learned from this, right, that we were looking at seasonality and gave us some efforts around the time of year, too. That wasn't something that we initially thought of. It seems like, oh, yeah, of course. But we wouldn't have known that until the data was right in front of us.
All right, I think we're about ready to kind of wrap up and summarize here, but
Yeah, so just quickly, I think as we've been talking along the way that, analytics alone is not enough. DJ and I have been, interacting here because it really is about analytics and it's about people. What was told in the beginning at the first session, right? We need people. That was what Brian said, the CTO from SAS said that this morning. We needed people through this entire process, not just leadership, but staff were involved as well. All staff that were customer facing or patient facing were really involved in this process. And we had a number of different wins, right? So, and you can read them here, but we were really being able to help improve our patient care. We were able to increase our efficiencies and cost savings. It ended up helping decrease our clinicians' stress and help with their satisfaction, the financial incentives as well, because again, their productivity is up, and then from the organizational's financial gain.
there were so many of those wins on there too that you couldn't even quantify from a dollar perspective, but the satisfaction is something that you guys, I know, emphasize as an organization.
Absolutely.
Like making your people happy, don't get burnt out, don't have high turnover, and that was an unexpected, I think, win with the application as well.
Absolutely, absolutely. And again, I think because of their buy-in, they were giving us things at the beginning. Hey, we don't want to be in back to back to back. We don't want overbooking where we're going to have to see 30 patients a day, because they need to be fresh. They're going to make a diagnosis of autism for a child. They need to not be burnt out for that appointment, right? They're making some really, critical decisions. So it was really helpful to, utilize their input as we were looking at data as well. So what we've learned along the way. So we've talked a little bit about this. We've done some rapid cycle improvements along the way. So we asked our clinicians, we asked our operations folks, like, hey, here's what the data's telling us. What are some of your, predictions? And then we piloted some things. So we ended up piloting some, things that we thought were big pain points and ended up not being as big of pain points. And then we piloted mostly things on the customer service side too. Again, at that micro level and that macro level area. And we piloted them each individually because we didn't want to throw it all at once to see, hey, well, okay, we changed that we're doing no-show calls for people at 60%. We're going to change our evaluation process. We're going to not do evaluations on our new treatments on Friday. Like, if you do too many things at once, it's hard to capture what is actually effectuating the change. So we ended up doing things for what we felt like every 3 months was throwing in a new solution and looking to see what impact it had. Again, you saw that month over month. We looked at the month over month trends too to see whether or not, like, how we were compared to months in this previous years, and looked to see whether or not those initiatives were effective. So, that's essentially what we had learned along the way. I know we have only a couple more minutes, but
yeah, I think we can probably. I think we got some time left for questions, and yeah. So I think we have a microphone here. If you wouldn't mind, if you have a question, raise your hand for the live streaming that they can hear your question.
Yeah, if you put your hand up, I'll come running. Anyone got any questions?
And while we look for someone who has I'm going to do a nice little plug that if you are an organization for no-shows, we have a really neat tool that shows that you can plug in your no-show rate, how many patients you see, and you can see how much revenue your organization may be losing. And then, if you were able to reduce that, what cost savings there would be. And there's a QR code to our site as well.
Hi, thanks for your overview. My question is around leveraging the social determinants of health to identify those and ultimately help to close some care gaps.
Sure.
One of the challenges with health data is an inability to collect a standard set of metrics that are defining social determinants of health. And I'm curious whether or not, in your experience, you've used a minimum data set, if you will, of core metrics, maybe housing, transportation, that you repeatedly collect, and then you're able to leverage in this solution.
Great question. So until about 4 months ago, I used to oversee our social determinants of health program too. So what we ended up doing was we actually have a really nice, robust social determinants of health program. We do it in a variety of different ways. So we collect that data via text, via email, and we also have a patient navigator team that goes ahead and calls families and goes through social determinants of health screening. In New Jersey, we have a lot of different languages, so we always make sure that we have language services available too, so that we're able to collect social determinants of health. Our rate, so I think the standard rate for most organizations, to your point, is probably around 10%. Ours, at the last time I checked, was over 50%. So that's something that we do, that we have some nice robust data in, and that we were able to feed into the model. The primary areas, we looked at the CMS's tool, the Accountable Health Communities tool, which tends to be standardized. There's some conversations about changing to maybe a Prepare or something like that, which might be more appropriate for pediatrics. But really the areas of housing, food insecurity, transportation are the main domains. And that's something that we were able to put into the model and then look to see what challenges were. And then we were also able to put in solutions from that where we have a social work team available and ready, knowing that social determinants of health obviously impact no-show rates. We call ahead of time and have a family navigator go through the screening tool, and if someone has a need, we're able to tell them at their next appointment that they can connect to a social worker who can help address those needs. And again, establishing a relationship of trust, which is very important, probably even more important than the data aspect here too. So I hope that answered your question. Okay, thanks.
Thank you. Can you speak more about I'm trying to understand the methodology behind your risk scoring, because I wasn't quite clear on, is it distance, is it demographics? What are the factors that goes into how you model someone who's high risk, a no-show?
So all of the data is input into it. Unless the statisticians find clearly that there is absolutely no correlation to it, it's then eliminated for that specific model. But it's not a, just we're going to focus on this, and then we give you a chart that says, okay, if you are in this demographic or this zip code or whatever, then you're going to be a no-show or not. It's put all of them. And we utilize all of the models that SAS has in the Viya platform to build them all, and then we use the model Score Champion. So it will then determine based on that. Now, for every organization, you could actually change their criteria depending on what it is that you're looking for as your success criteria to be the most accurate model. For instance, are you looking for the most correct negatives that we got to find those who are not going to show up, or are we looking for a balance of it? Is there a financial profit or loss around it, depending on the type of appointment, right? There's all kinds of things we could do. So we could put a profit matrix on it. So if an appointment has maybe a medium priority of being a no-show, but it's an MRI and it's going to be a very expensive no-show versus a PCP, right? That model may be completely different. And so we have the ability in the SAS platform to put all kinds of factors on it to determine what is most important for you as an organization. But to answer your question, everything is kind of fed into it, and then it helps determine, is this an impact or not? And then it'll discard those that have no meaning on that particular set of data for that clinic, that practice, that subset of patients. Does that answer that?
Yeah, thank you.
Yeah.
I think we're actually out of time. If you guys have any more questions, I'm sure Vicky and DJ can give you a few more minutes toward the back of the room if there's anything else from the team. But I'd love if you could show your appreciation for the guys for their time today. Thank you.